I'd like to welcome everybody to our grand rounds. This is a unique type where some of us are on Zoom and some of us are there in person, and we're very excited to get the show rolling. So Sam, if you want to do the formal introductions, that'd be great.
Okay, perfect. Sorry I can't be there in person, but I'd like to introduce Dr. Kim Rhodes, who is an amazing mentor for me. I've learned a lot and much, much more to learn. She holds multiple different roles within UCSF and outside, including Director for Community Outreach Engagement within our Helen Diller Family Comprehensive Cancer Center, Associate Professor of Epi Biostats, as well as founder of Emoja Health Partners, which is community coalitions initially formed to address COVID-19 and health-related needs of underserved communities of color within the Bay Area. From an education standpoint, she initially earned her bachelor's in linguistics and then joined the joint medical program between Berkeley and UCSF, later completing medical school and residency in general surgery, and then obtaining an MPH in healthcare policy and management. Her background and scholarly work spans the entire cancer continuum, from basic science to clinical work through health services and training in health policy. And she was the inaugural Philip R. Lee Fellow in Health Policy as well. She's had formal training in community organizing at the Center of Third World Organizing in Oakland, California. Community-based participatory research is a member of the first cohort of academic community partnership teams trained by the California Breast Cancer Research Program. And before joining faculty here at UCSF, she founded the Community Outreach and Engagement Program at Stanford Cancer Institute. She views community engagement and institutional partnerships as substantive pathways to promote health equity and eliminate cancer disparities. And I have read much of her work, and it has helped informed how I approach disparities as well. So happy to have her here and give us a talk about how health equity requires action.
Thanks, Sam. It's kind of weird because I don't know where you are or where to look for where the other people are in the room. But I really appreciate the invitation to present really kind of my thinking on what we need to be doing or how we need to be thinking differently about how we get to health equity. We talk about it a lot. But I think that what's missing is the action piece. And I hope to convince you that that is true and that we need to do something different. So first of all, I just want to say I have no financial disclosures, but I do, I think it's important to disclose that I'm a first generation college graduate. And pictured here, you see my great grandmother on the left, Miss Mary Lee Chambliss, who grew up in a time when it was illegal for Black people to learn how to read and write. More importantly, it was illegal for Black people to learn how to write, which you can imagine limits the way you can document the history of your experience. But she was a resistor and she learned how to write her name. My grandmother went to high school and my mom finished 2 years of junior college. And the reason I raise this is because I want people to really have a real sense of how many generations from the time of the most sort of structural limitations and racism in this country, how many generations it takes to get one college graduate. So that said, you heard about my career path. The academic parts I think are important, but I think what's more important actually is the education that I got in the community. So throughout my time from medical school until now, I've always worked in the community. I've always felt compelled to work in the community and without really any specific reason or impetus, but I am also obviously influenced by the life of my Aunt Jeanette, pictured here in 1985. You can see the hairstyles and the glasses kind of give away the decade. These are my cousins on either sides of her. My Aunt Jeanette was 58 when she was diagnosed with a locally advanced breast cancer. It had actually erupted through the skin. And she was admitted to her local safety net hospital and given IV antibiotics. There was no radiation machine, and she died in the hospital. And I bring this up partly because I just want to share that, you know, in between college and medical school, I moved to Washington, D.C. And I spent a lot of time in Virginia with my family. And part of my process of thinking about medical school and approaching the application was conversations with them. And one of the questions that I remember asking my aunt was like, we were just driving around town and I was like, can just kind of like want to talk about and think about like, what is it about Black people in healthcare? And I didn't really know what I was asking, but what she said was, I wish I could go to a clinic where people knew who I was. When I walked in, they knew me. I said, hi. I mean, it's like cheers. I always think in my mind, it's like cheers. Hi, Jeanette. But what she was looking for was community. What she was looking to not have happen was to be judged for whatever decision she made about her life that may have contributed to where she was in her current circumstance. And I think we do that all the time, right? We talk about delay and patients are non-compliant, and there's a way in which that is not inviting to key communities to be in our spaces and to get the care that they need. So I leave that as an aside because that colors everything else I'm going to tell you about how I think we need to shift what we do. What I want to say is that, I don't believe that had my aunt gone somewhere else, that she would be alive, right? I don't think what was going on was going to be survivable. I think her death could have looked a little bit different, but it is what it is. Disparities in cancer, though, are longstanding. They're just, old. And what I'm showing you here are historical trends from the SEER database of lung cancer mortality, colorectal cancer mortality in the middle, and breast cancer mortality. And these are specifically for the state of California. To get you oriented, can you see this pointer on here? Okay. The blue line represents African-American trends. The white line, or the red line represents trends for white patients. And then down below here in orange, dark green, and light green are communities that we never talk about who have lower mortality rates that we don't use as comparators. I just want everybody to kind of think about like why that might be the case. But what you can see is that the disparities gaps are wide and relatively persistent over time. There's some subtle things that I will say here, which is one of the things that you see here in breast cancer is that the African-American or Black population is on its own trajectory in terms of mortality coming down. But why is the gap widening? The gap is widening actually because this line, the red line, is actually coming down with a faster slope. So it's not that things are getting worse here. They're just getting better here, and they're not getting better here. I'm not going to really focus on that, but I just want people to think when you look at these graphs and you look at disparities gaps widening, we always look at the minority population and say, what's wrong with them? And I want to ask, what's wrong with us that this other line is getting better quicker? Because I would suggest it's probably some advancement in technology or care that is not getting to everybody. Again, my aunt was in a hospital with no radiation machine. Just still, 20 plus years later, still kind of blows my mind. Okay, so our traditional explanations do focus on individual responsibility. We looked, I've been doing this work. I started as a medical student in a master's program with the joint medical program, reading all the literature, and it was basically the patient's fault, no matter which way you sliced it. And in fact, there was a debate about whether or not disparities were real. So it's easy, I think, to sort of blame the patient. Chronic diseases that are poorly controlled, late stage diagnosis, these are all true. I'm not saying they're not true, but there are ways that they sort of funnel how we think about what's going on in disparities. And then the genetic explanations are ones that really get me because, as I showed you, some of the trends are changing over time. Our genetics are not changing at that kind of pace. So that can't be the only answer. When you look at cancers that are uniformly kind of aggressive, like pancreas and lung cancer, you see the disparities are kind of small. But when you look at cancers that have that require well-coordinated, high-quality, evidence-based care, you see the gaps get really wide. And so this should make us think about like what's happening on our side versus just what's going on with the patient, because this distribution doesn't match demographics. So in the 2000s, of course, it was the surgeons, and that makes me very happy, started to really ask the questions about hospitals and how well we do what we do, and looking at high volume hospitals, for example. And this led to another kind of explanation about disparities, which was that perhaps Black patients in particular are not using high quality hospitals, and that's why their outcomes are worse. And this kind of made sense to me because I think you see it as you rotate through UCSF, you see the different distribution of patients in different settings. And so I started looking at a marker of payer mix and asking a question: are racial and ethnic minorities clustering in high Medicaid hospitals? And the reason I would focus on that is because cancer care is expensive. You have to have a lot of equipment. And if your payer mix is not that, fruitful, I'll say, you may not have some of this kind of equipment. And what we found when we looked at just at California, and I'm not going to show you the whole paper, I'm not going to do papers, I'm just taking snippets from each of the papers to kind of make an argument here. So we could see that racial and ethnic minorities were clustering in hospitals that served one standard deviation above the mean for the state of Medicaid patients. And just to confirm that we were not, didn't miscalculate, you can see that in high Medicaid hospitals, you have a higher proportion of people who have Medicaid or no insurance. So the definition is works, has face value. So then we asked, why are racial and ethnic minorities clustering in these hospitals? Why aren't they going to high volume hospitals? And I think our first explanation is usually because they live too far away and travel distance and all that stuff. But what we showed here was that racial and ethnic minorities in California live closer to high volume hospitals than their white counterparts. But when we asked, do they use the high volume hospitals? The answer was no. And the distance we used here was 5 miles, because that's the median travel distance for colorectal cancer care in California, calculated as a straight line as the crow flies. So then we asked, well, what about NCI hospitals? Because we know the outcomes are definitely better. Do racial and ethnic minorities live far away from them? And the answer is no. They tend to live closer because NCI centers tend to be in urban settings. So what we actually saw was that racial and ethnic minorities were bypassing these closer hospitals to go to some other hospital, which was, as I showed you, the high Medicaid hospital or the low resource hospital. So then I wanted to test travel distance, and we did this for the NCI hospitals, and I want to orient you to this data depiction. So in the center here of each panel, there are 3 panels comparing NCI utilization for Black patients versus white patients, in the middle for Latino patients versus white patients, and then for Asian patients versus white patients. The red line in the middle of each panel represents an odds ratio of 1. So if the dot in the model is to the right of the line, there's a higher odds of utilization. If it's to the left, it's a lower odds of utilization. So first we looked at a baseline model, and that baseline model included age, gender, stage of disease, year of diagnosis. And what you can see is that there's a lower odds of utilization for Latino patients and a trend toward such for Black patients, although it crosses 1. Then we wanted to factor in travel distance because that's our big explanation. We just need to get everybody transportation, all be okay. And what you see is that travel distance does have a negative impact on utilization of NCI centers. But then when we factored in neighborhood level characteristics, so here we used education, we could have used income or neighborhood level economics, you see that the pendulum swings back the other way. And in fact, it neutralizes the difference for Black patients and brings us to a null result for Latino patients. This started, kind of had me thinking like, maybe we're doing this wrong. Because I think what that data is telling us is not like, oh, you're smarter, so you use the right hospital. There's tons of literature showing that people don't pick their hospital on the basis of quality, right? And what I just showed you is that you pick the hospital that your neighbors pick, right? So it's about the relationship that you and your neighbors and people who are like you on a socioeconomic basis pick or have a relationship with that hospital. So in terms of answer the question, why do people go where they go? I think that, and thinking about the fact that where you go can have an influence on outcomes and disparities, I just started to think like maybe we're actually approaching this in the wrong way. So I'm going to share kind of what I've learned being the Associate Director for Community Engagement in the Cancer Center. And I'm going to use our esteemed former chair, Baba Arnold Perkins, who was a founding member. So he was with us for 17 years. He was the chair for almost 10. He is a prostate cancer survivor. I know a lot of you who have been here for a while know him and know him well. He's very wise, and he's got a lot of great sayings that kind of help me think through how we approach community engagement here at our cancer center. So I'm going to start with this because it's a little bit of an excursion, but it helps, I think, to understand where people go to get their care, why people would be willing to bypass a better outcome hospital, and how that interface that my aunt talked about, like how that evolved and continues to evolve over time. So Baba Arnold says things in meetings that are just, sometimes they actually make me laugh. And I have a piece of paper called Arnold Says. And so I'm typing things that he's saying because he's 80 now and need to preserve his legacy. He's done a lot for the Bay Area. And one of those things is to shape, again, my thinking around community engagement. So this one is, he says, the 400th year anniversary of the enslavement of Black people. I'm like, why would that matter? So I want to just take you on a little tour here about the origin of others. And I want us all to think about otherization and what that means and how it works. And here I'm going to use Black people and slavery as the example from Toni Morrison's book, The Origin of Others. First of all, African-American people are not immigrants. And I think we think of everybody who is foreign or different in some way as like immigrants. Black African immigrants and African immigrants who are not Black are immigrants. African-American people were brought here. We didn't come for, to make a better life and to have more opportunities. But the problem is the human traffickers had to kind of come up with a reason why it was okay to do what was being done. And so slavery effectively required what Toni Morrison refers to as otherization in order to justify itself. And I actually brought a little, I want to read a passage from the book that allows for you to think about slaves as needing something from the slave owners, and for slave owners to feel pretty good about what they're doing. So this passage states that the forced exercise so beneficial to the Negro is expended in cultivating cotton, sugar, rice, and tobacco, which but for his labor, the slave's labor, would go uncultivated, and their products would be lost to the world. So both parties are benefited, the Negro as well as his master. I mean, I have to laugh because it's just such a ridiculous argument, but it effectively creates a way in which it's actually okay to do what is being done. And unfortunately, that status was then medicalized and preserved over time. Like, yeah, these folks over here who are not quite human have different diseases. And some of that persists, and I'm not going to get into that, but some of that persists over time. I do want to say that otherization is not just applied to Black people, right? Anybody can be otherized. Women in relation to men, LGBTQ community in relation to the cis hetero community, patients in relation to doctors, right? We are not others from each other. We are all the same flesh and blood, have the same vulnerabilities, and can at some point be the patient. But there's a way in which we are taught that we cannot be the patient. And unfortunately, and I understand that, like the need for the psychological separation, but the unfortunate fact of that means that what you have to do is blame the patient for some things because it keeps you separate. Well, I'm not smoking, and so I'm not going to have that problem, right? So just try to see how that's operating kind of in your everyday world. So otherization extended into education, which meant that Black medical students could only train in certain places, can only do residencies in particular places. And then that meant segregation in healthcare, right? You could only practice in certain hospitals. It meant your patients could only come to certain hospitals. And then you've got redlining. You can only live in certain neighborhoods. So you start to see how people are picking their hospitals, not on the basis of quality, but actually on the basis of historical factors and sort of the culture that develops in those neighborhoods that were, forced by structural factors. So I just want you to stew on that and understand that may be why, as folks are coming to me in my job and saying, well, I'd like more Black patients in my clinical trials. Like, well, you got to get more Black patients to the center. And then you have to ask, well, why won't they come to the center? And then we have to stop and think, are we doing anything different or special? Because if we're not, the fact that we don't have a relationship means that they're not coming here. They're going to go where they have a relationship. Okay. So there's that chapter. So now, after all is said and done, another quote from Baba Arnold, a lot more is said than done. And I just think this is hysterical. As a linguist, it really captures the essence of what we're doing around equity, talking a lot, meeting a lot, making blueprints. Are we doing anything? As a surgeon, it makes me think, why are we not taking action? And I know you can relate to that, right? Like you see a problem, you're like, solve it. That's the nature of the surgeon. So I want to point out that describing disparities is not going to get us to health equity. There have been some really great descriptions of how things can go wrong. If you're not familiar with this paper, you should pick it up and read it. It's kind of fun. It's basically video vignettes of patients who are either Black or white, male or female, old or young, giving the same description of the same symptoms and getting different recommendations for treatment. And it's hypothetical. So it's not that people were really harmed in the process. However, this paper that Lenny Lopez out at the VA, head of hospital medicine, wrote many, many years ago, we used to jokingly call chest pain while Black. And what happened here is over millions of patients in ERs across the country, Black and Latino patients reporting chest pain, not getting aspirin, not getting assigned to a tele unit, not getting triaged emergently, all that stuff. And then in cancer, written multiple papers about different kinds of cancers and how this kind of plays out in the same ways. And can lead to disparities. But the problem is these papers aren't changing anything. They haven't changed anything and they're old. And I think that's because we're stuck in what's called the knowing doing gap. In the knowing doing gap, the things that we do are describe things, point them out, say they're bad. We create blueprints. And I would argue that even all the DEI training that we're doing on campus is kind of some part of the knowing doing gap because we don't evaluate it. So we don't know if it's working, but we keep doing it, right? So we're not actually moving the agenda forward. And instead, we're kind of doing things that are twittering around the edges as substitute for action. So we need to really think hard about doing something. With that said, I want to say that my call to action for all of you is to think about dismantling the status quo. And I am definitely not I used to be a blow it all up, right? Because the reality is if you blow it all up, then we have nothing. So we have to think about, taking it apart and putting it back together in different ways. There are some good pieces of what we have. Problem is those pieces aren't working for everybody. So they need to be restructured. And there are ways that I think everybody can do that in your daily practice. You're not necessarily going to change systems, but just being conscious of the fact that some changes may be necessary and may be impactful. So that when you get to a position of formal authority, for example, that you can start to think about, how do I make these changes? You need a plan in order to act. So that's my point there. So why should we dismantle the status quo? It's based on deficit thinking. First of all, deficit thinking sees only what's lacking, right? What does the community need? Like, I think the community needs more education, right? So I'm going to get out there and do that. Well, the community might not need that. They might need a job. And if you help them with a job, you might get to do some education. So it fails to see the assets that are already there in the populations that you think are facing disparities. And it blames individuals, as I think made the argument. And then the last thing for me is that the status quo is really comfortable for some people. And so that can breed complacency. And complacency leads to inaction. We'll just keep doing the same thing because it's working fine for me. So I want to give you now an example of how we tried to use this different framework to address COVID-19 inequities in Alameda County, and then now kind of across the Bay Area. But this is where we started. We were asked to come over to Oakland because it was very obvious that the concentration of infections were in this deep East Oakland corridor right here. I have Roots Clinic shown here because that's a clinic that traditionally serves Black people. And in fact, they were the first to set up no barrier testing in Alameda County. But look what happened. When you come down to this map here, you see that the folks who live around it weren't really using it, although in Fruitvale, they were crossing zip codes to get there. But everybody in North Oakland was coming down to Roots to get their testing, right? That's not where the infections were. So there's a huge mismatch here. So what we needed to recognize and not taking a deficit lens is that each one of us is a piece of the puzzle and every piece is important. And Baba Arnold says this to me all the time. And every time I tell him I'm showing these slides, he says, and remember to say that every piece is equally important. And the challenge is to figure out what is that thing that somebody's bringing to the table that can be leveraged for a bigger agenda. So we gathered all partners, many partners. There are many more than this. I think this might be an old slide. Through the Friends of Dr. Frank Staggers. Dr. Frank Staggers was the first chair of our community advisory board and actually was the person who said we need an agenda on prostate cancer and African-American men and disparities. And they connected us through the Brotherhood of Elders Network, who introduced us to Roots, who introduced us to BOSS and Health Leads, and they gathered this group of folks. And then as we started meeting, more people started signing on. So we've got elected officials, academic institutions, federally qualified health centers, CBOs, and faith-based organizations. This is probably my favorite quote from Baba Arnold. It's probably the first thing I wrote down that he said. You can't teach what you don't know, and you can't lead where you won't go. So if you're not willing to be out in the community, you're not, let me say, if you're not comfortable in the community or not comfortable with community people, it's not going to work. You have to be willing to be next to people who you think of as other, and you may think of them as other in a threatening way, right? You have to ask yourself why, and then understand that if you can't get over that, you won't be able to lead for change. So we built up the coalition, as I mentioned, lots of important partners, including the public health department, who is willing to give us these heat maps and this data. And we asked them, where do Black people live in Alameda County and in Oakland? This is mostly focused on Oakland here. And they gave us this map that shows us by heat distribution, where there are more than 40% of the population was African-American. And so these little green dots show where we decided to set up all of our COVID distribution activities. Initially, it was just hand sanitizer and loud messages, and then it evolved to testing and vaccination. We asked our big coalition, like, where are Black people going to be gathering? So the Acoma Market was actually the first COVID services pop-up in Alameda County. We had already done the first one in San Francisco, and that was before what you're seeing now. So that was back in June of 2020 was the first where we just popped up in the neighborhood on the street. And what we saw was neighbors knocking on neighbors' doors, pulling them out of their houses to come and get tested. So we asked in Alameda County, where should we be? They said Acoma Market is opening. It's a Black farmers market that opened during the pandemic. We designed materials that specifically were targeted to and speaking to the African diaspora in terms of the color, the messaging, and then we leveraged the fact that neighbors know their neighborhood, and we had people on the street answering questions about COVID, not forcing people or guilting people into anything, but just letting them know that the services were going to be available in their neighborhood. We created a logo. Branding is super important. People now see Emoja and they think they have all kinds of thoughts about what they could potentially get, which is great because it's not limited. And there's no judgment because these are your neighbors. So I'm just going to run quickly through the early stages. And like when we did the testing, African-American people were like, I'm not getting tested. You're sticking something up my nose. You're probably giving me COVID. That was the thing we heard repeatedly. But then when we have finished in Alameda County, what we saw was that about half of the people that we tested were first-time testers, and the bulk of them were African-American. And it was because it was very intentional. We're saying we're bringing these services in your neighborhood for you. You don't have to take them, but we're here and we're not leaving. And then when we compared ourselves against the clinics that traditionally serve African-American people, week by week, what you could see was that Emoja was doubling and tripling the reach to African-American people that these clinics had. These clinics were set up as traditional kind of brick and mortar. So basically you needed a car and a computer. We were in the parking lot at BART. We were in the parking lot at a liquor store. We were on the street in a random place where Black people would be passing through. So you can see that strategy works. And then we were asking people, are you open to the vaccine? You can see African-American people were only at 40%, but when we compared that at the time to the national average, we clearly had bested that. We were at 32% for African-American folks. And then when we asked, are you willing, can we contact you for research? That's always the last question on the survey, right? We didn't have anything planned. And people said yes, but what we were shocked by is that the largest group of folks who said yes were African American. Based on this, we were given our own vaccine allocation by the public health department. And so, as I said, we showed up in very uncommon places to do what we do. Everybody was dressed the same. I wore the same outfit, the t-shirt, the jeans. You can ask Sam, he came out and vaccinated with us, t-shirt and jeans, Umoja Health logo, effectively communicating that it's your neighbors who are taking care of you. It's community. It's effectively what my aunt was looking for, right? So just kind of briefly to make the point that we also, because we were so intentional and so focused, but not exclusive, right? The majority of people we served were Black and African American. And then we set up a call center that was regular folks making the phone calls to say, hey, you know, your second dose is coming up. So we had the highest second dose completion rate in the county for Alameda County during that time. Now, I don't want to give you the wrong impression. This did not happen overnight. Our community advisory board in the cancer center was started in 2005. So it was a long time ago. And they really were the ones who encouraged us. They said, you know what? Yeah, cancer, but we need information about COVID right now. Dr. Hoggood then funded the United in Health initiative in Bayview Hunters Point, which I led. And why did he ask me to lead that? Because I already had partners there. We already had a relationship. We were working on other issues, cancer and environmental exposures. So we were able to gather a coalition pretty quickly there. And then we were called over to Alameda County, and Umoja Health kind of took on effectively a life of its own. We had folks from San Mateo call us and say, how can we make our own Umoja? Then we came back to San Francisco and said, how can we grab the partners from United in Health D10? And now we're Umoja Health Bay Area. We started our first paid internship in 2021, and our youth mobilizers crew, who do all of our messaging, handle our social media accounts, which the old people really shouldn't be doing because we're not that cool. And then this was our first anniversary where the mayor of Oakland proclaimed Umoja Health Day because of the impact that we had had, not just with the communities we were working with, but across Alameda County. At the end of our testing stint, Black people in Alameda County became the highest rate of testers in the whole county, which was insane. So then we graduated our first summer class. We're now on our third cohort. We just selected them yesterday, and they made their own logo. And then this translates into other benefits for our academic careers. So now I co-lead for community engagement, the P50 centers that NIMHD funds to the tune of a $200 million portfolio, which is called the Health Equity Action Network. And I don't know if you can see the similarity between the Umoja logo and this one. And again, it has the word action in it because I insisted, like, I will not work on this unless we're really going to make change. But the big impacts are nearly 200 weekly meetings, because that's really what we were doing to amplify the voices of community, allow them to talk directly to public health, to our academic health systems. UCSF Health now gets on the the San Francisco Umoja meeting. Stanford is in the San Mateo Umoja meeting. And so you can see that that's a little weird because we're competitors, but we're all at the same table with the same goal, which is around population health. We've knocked on tens of thousands of doors, hosted more than 200 pop-ups. We've done about 10,000, it's probably more than that, tests and vaccines, largely to African-American community. Most importantly, we have helped because at the end of each meeting, we announce funding opportunities, and then we write a letter. And because I'm here, I can write it on UCSF letterhead. That has helped our partners get $2.5 million in their own money into their own pockets, not a penny coming to UCSF out of that. And then most importantly, out of all the young people that we're training and fostering, we have one guy who started with us as the door knocker and the mobilizer. He's now a certified medical assistant. He gives shots on site. He gives his family health advice, right? He feels connected to some larger something where he can get that kind of advice. And then we've got two folks in medical school. One is MD PhD, and for his PhD projects, trying to start Umoja in North Carolina. For that, we've got a new entry into the master's nursing student program at Davis. One's getting a job at Genentech in the business section, which is important. We don't all need to be doing the clinical work. And then we just had one get into the Pathways to Public Health Fellowship. So this addresses the thing that was happening at the beginning of the pandemic where they're saying we don't have the right voices around the table. This is economic development for different communities. This shifts the relationship between UCSF, not on purpose, because you saw there was no UCSF branding, right? But it shifts the relationship between UCSF and families who are touched by the network that we're touching. And then we went ahead and translated this into, we used our community health work educators in the cancer center. So that's a specific program funded by NCI. We combined it with Emoja. And then we started using these platforms to educate people about getting screened for colorectal cancer. And we actually started handing out screening kits. We produced new materials. These are real people with real stories. And we do it in Spanish, English, traditional Chinese characters, Tongan, Samoan, and Fijian. And how do we do that? Our partners speak those languages. So we produce the materials with them. They then translate for us. We have now put these kinds of cards out, I don't know, maybe 50, 60,000 of them all across the Bay Area. Some of you may recognize Baba Gerald Green. He is a longtime patient advocate here. He is prostate cancer survivor, as well as head and neck survivor. And then we put up a billboard on 880, and we put signage on BART. This is our newest signage for BART, features the stories of patients from the community. And Miss Rosie, of course, her story is intreatable. You'll see these posters all over BART. And we've actually gotten some phone calls about people like, I have a bleeding breast something. And then we use the network to navigate them to where they need to go because we have a network. So you can see that we've reached millions in this process. And actually incorporated and started to use it really directly for screening. So any blood-based testing that we're going to be able to do, any HPV vaccination, which is cancer prevention, we know how to do vaccinations, right? So this is a platform where people can be part of the solution. And I just want to point out that when we look at outcomes for mortality in COVID for large counties in California, population over 500,000, you see the top 3 are Emoja counties. Same with vaccination rates and the booster rates. And these are Emoja counties. And what I don't want to say is, oh, there's no disparities and don't worry about it. But what I do want to say is the public health department and our academic institutions now interact differently with community. And I think that's why our 3 counties look the way they do. Okay, so rounding the corner here. I think what I want to really emphasize is that, as Bob Arnold says, if you want to have what you've never had before, you have to do what you've never done before. And we have really done something different here, right? We have not, we're sort of agnostic to where you get whatever care you're going to get, right? We're just directing traffic, but we're also opening a portal then for, as I said, community members to be part of the solution and for our healthcare partners around the Bay Area to be in partnership with us for population health. So why does it work? Because we emphasize and cultivate an ongoing relationship. Our actions are intentional and they're focused on the African-American community. We have deep community engagement. And that means that there's action, and it's not action just being taken by us, action being taken by community members. And then the education piece is not just a lecture, right? It's learning through the actual activity. All of our pop-up sites set up by community. I cannot show up until we're ready to go. It will be set up and arranged in a way that somebody has thought about the flow, the safety, the information that people are going to get when we do food boxes. We, of course, we put the vaccines first, and then we do food boxes over here because you got to go through this before you get that. And then we do the regular meetings, and they're continuing. And I sometimes ask, I mean, the Emoja County, the Alameda County meeting is growing. So we had almost 80 people on the meeting last week. And I just continue to ask myself, like, why are people continue to show up for this? But they're looking for information. They're looking for policy analysis around whatever's changing that centers Black people. So it's not just the status quo, the pandemic is over, and you can see I'm still wearing a mask. We don't just say that. What we say is, okay, the rates are lower right now. Where are they lower, right? What does transmission look like? What does the pandemic ending look like? And so now what we're focused on is the fact that a lot of people are going to lose their Medi-Cal. And folks didn't know that. But the pandemic, the public health emergency being over is really the public health emergency funding is over, right? So now we say as a network and as a coalition, what can we do together to keep people safe? And they're participating in that conversation. So I think that's why people continue to show up. All right, so our traditional approaches really have been outreach, and I'll do a little thing on outreach in a second. Hate that word. We describe disparities, and then we have extractive relationships where we say, well, I'm working on this project, so I'll work with you on this, and I'm really nice and it'll be fine. But if you're not talking about that, don't call me because I can't help you. We're saying we're non-transactional. We'll work with you on a project, or there won't be a project, we'll still work with you. Or you want COVID, we'll give you COVID, right? But if you then call us around cancer, we're going to help you with cancer. So in the past, I would say 8 weeks, we've navigated about 11 people into cancer care. And it's just through a phone call like, oh, Emoja, like, can you help me? And of course, the answer is yes, because we're connected to a lot of stuff. Okay, so I just want to say something about outreach. I don't like the term because, and as a linguist, it matters, the language that we use, because it shows kind of where your orientation to the situation is. And the reason I don't like it is because it's unidirectional. It's one way, right? This is a university. And what is it going to take? It's going to take data. And then the arm is going to go like this. And then the grant's going to be over. And then that relationship is going to be over. What we want is something that's cross-sectional, something that happens over time, over the long term. Outreach also preserves the old power dynamic, and really is like the university has the power and the community has nothing, and it's deficit-based. It's like, well, we're bringing something and you should feel, grateful that we're bringing it. And it doesn't look for what can the community bring to the table. When we first started the testing, if people tested positive, we were delivering groceries to them. And it was really funny because I had this it was one of those things like in the middle of the night, you're like, what would we do without the community partners to deliver the groceries? Like, we don't know how to deliver groceries, right? Yeah, we can do Instacart. That's expensive. Community gets food through different networks that they had already established before the pandemic. They know which neighborhoods they can go to and which neighborhoods they can't. Lots of local politics in San Francisco. So it made me realize that's an asset in the community that we could be leveraging. But instead, when we come, we're like, okay, we're going to do food as medicine. We're bringing all the food. We're going to distribute it. We don't know the neighborhoods. So we lose some effectiveness, I think. So I would argue that we should stop doing outreach and we should start reaching out. And by the way, outreach is a noun. So you're doing something to people, which is gross, except for when you're operating. But reaching out is a verb, right? You're doing an action. And you're expecting someone to reach back. When you do outreach, you're not expecting anything because they don't have anything. It's deficit thinking. So think about reaching out instead of doing outreach. All right. To get out of the knowing doing gap, we need to meet people where they are. We need to stop writing papers about how bad it is. One of our collaborators in Michigan in the P50 consortium says, how many papers do we need to write about you're Black and you're poor, and so therefore the outcome is going to be bad? We know that. So what are we doing about it? Try to pay attention to the systems you're working in so you can think about systems change as best you can. You won't always be able to make those changes, but you need to be aware of what needs to change because you're making your plan for when you're in that position where you can make that change. And then we need to bring the institution closer to the people instead of always asking them to come to us. And I think that's part of why this pop-up platform works. And I think it's like a cast iron pan. You could cook anything on it. Right? It doesn't have to be COVID. It could be anything that we're bringing out into the community, including clinical trials. And then deliver care and resources in collaboration with the community. Ask the community where you need to be. They'll tell you. Then they'll get the people there. And remember that trust builds at the pace of the relationship. We need to, as academic institutions, we need to provide that long-term, that longitudinal, that relationship, because your careers, the reality of your careers is that they go in these little spurts and segments, and you might not be in San Francisco in 5 years, right? You might go off and do a fellowship somewhere else. You might practice somewhere else. So we should stop having the relationships be like, oh, I know Dr. So-and-so, but instead I know UCSF. And that's what we're trying to do in our office. So if an individual investigator is working with a community partner, we want that community partner partnered with our office, because when the investigator leaves, our office is still here, and we're committed to year-round, non-transactional community engagement. So we'll still be here, and you won't have the community saying, oh yeah, the academic partner always leaves. Finally, I would say effective health equity research has to incorporate meaningful community engagement across the entire spectrum of what you're doing, from developing the questions and understanding how the results will land on the people you think you're trying to help, to implementing the study itself, and then to interpreting the results and then getting the word out. They're better at that than we are. That's the world that they're living in. And so we should bring what we bring to the table. They bring what they bring to the table. We maximize our output, because everyone is a piece of the puzzle and every piece is important. So I want to just hope I convinced you that health equity requires action. And for those of you who want CME credit, please scan this code.
Awesome. Thank you so much for the talk. I love talking about this in general.
Sorry, I wanted to just show the totality of Umoja Health. And this is separate. Some of these folks are part of our cancer center network. I mean, they all are now, because everything we do in the cancer center now, these guys get to find out. But this is really, these were the groups that were focused specifically on COVID during this period. So that's really the end. Thank you. Happy to take any questions.
I don't see any yet in the chat, but I had a question. Now, for a lot of people trying to do research.
You know, you're stomping on Peter here.
Oh, sorry, I can't hear him.
So one of the questions that we've had over the years on reaching out for cancer screening was, how do you ensure that once you identify a cancer in the community, that patient gets good care? And especially for something like prostate cancer, where we find these great variations among all people on quality and appropriateness of care. One thing I've discussed over the years is, how are you ensuring that the cancer that's detected by reaching out efforts they get great care?
Yeah. I'm gonna
maybe repeat that.
I'm gonna go back to this. So the question was, how do you ensure, once you screen in the community, how do you ensure that people get high quality care, especially with prostate cancer? Is complicated. There's a million different pathways. Some of them are crazy. I know I've had some cryo things that are happening in some spaces. And the answer to that is this. I went back to this slide because it's the network, and I think we were on site at the Black Cultural Zone, and there's some old man wandered by, and he was like, "Oh, vaccines. Yeah, I had one, but I got to get the second one. I don't know, you know." And so then we were like, okay, maybe we can help you. And so we start to scramble, and the scramble is, who do we know? Right? So text messages start going out, phone calls start going out. So like, what neighborhood do you think you got your shot in? And then we were able to connect within 5 minutes to somebody who was able to look in the state database, which we now can do on our own. But look in the state database, tells where he got his shot, who gave it to him, what date, what shot he got, so that we were able to complete his series. And that would, like, for me, was like mind blowing. It was like, that's Umoja, because now when we're screening for colorectal cancer, because we have Kaiser around the table. So if somebody has Kaiser, we now can just do a text message, and guess what? You're going to Kaiser, because that's where you have to go to follow up with that positive test. Otherwise, we're asking, okay, what insurance do you have? Where do you live? Right? And through this network, we're able to funnel them to where they need to be, where they can be if it's limited by insurance. And obviously, there's a bias toward, if you can go anywhere, there's a bias toward where you might be connected. And so that's why I was mentioning these 10 cancers that we have already navigated really were by text message through this network, or people who are in other networks from having trained here, for example, having worked at Stanford, for example. And so that's actually how we ensure it. We pay for our own, and this is a weird kind of parallel universe. We pay for part of a Quest portal. So we get the results back ourselves. We reach out in a different way than other people get the results. You get a phone call, you get a conversation, even if it's negative. And then if it's positive, you get 2 phone calls. And what we want to know is, do you have a primary care provider? Because if you don't, that's the first thing we've got to get you signed up for, because sometimes that's how you're going to get that referral. So because we have such a broad network of partners, we're able to funnel people actually pretty easily. Knock wood.
So tell Sam you can ask this question.
Sam, can you, I don't know if you heard all that, but we're ready for your.
Perfect. There was one question that came through the chat from Yi. Great talk, amazing to hear the work that's been done. And he had a question of whether or not there have been similar efforts or platforms in the pediatric space. There's been assumptions about kids all getting the same healthcare access, but there are clearly inequities and room for impact.
Yeah, no, we have not extended the efforts, I would say, to the pediatric space. Although we have been invited now to sit with the Anchor Institution Initiative in Oakland at Children's Hospital Oakland. And I think it's because they want to plug into our network, which is, fine. But these efforts can be built. So if there are people who want to take action, I would be happy to support, what that would look like. And we do have, as I said, because we're part of this Anchor Institution piece, and because we have relationships in Alameda County with CHO, we can do that. So I'd be happy to talk to anybody, because as I mentioned, when San Mateo started, it was because a faculty member called me and said, what can we do in San Mateo? And I said, well, we have some partners in San Mateo. How about you meet? And now they lead Umoja San Mateo. And they, and then they gathered the networks based on the community partner, knowing who needed to be around the table. So we definitely can make the connections to help something like this move forward. The one thing I will say is, and I like the way the question was phrased as about kids not having the same access. So it's a generic question, because when we started working to help the Wisdom study, which is the breast cancer precision screening study, they were doing just like everything was Wisdom. Everything was about the study. And somebody from Umoja, who I brought onto their advisory board, said, why aren't you doing this like Umoja? Which I just think is also very funny to say, like, why aren't you giving just general information about breast cancer on a regular basis? Because when you do that, that's the engagement that's going to get people to say, oh, I should sign up for this study. Part of the problem with clinical trials is that there's a gap, right, between us and the patients, as usual. So that gap gets filled with suspicion. When there's a relationship that's about other stuff, then I know when you ask me to be on a trial, you're not just asking me just because you want me in a trial, right? You're asking me because we're in relationship. So, I don't know who asked the question, but please be in touch with me. And let's think about, how are we getting information out into the community about various pediatric issues, or whatever it is that, key partners want to focus on, so that we can develop some, ongoing back and forth exchange that then starts to facilitate some other kinds of conversations.
I can't tell if there are any other questions over there.
No, so far, no, I'll tell you.
Okay, I did have a question. So for trainees or people who are interested in doing work on disparities, either within the institution, outside, using data sets, there's obviously easy ways to look at a single measure: time from diagnosis to treatment, race, Black versus white. How would you advise people to start looking at these questions in a different way?
So I would say, thanks. That's I like that question. It's got some nuance to it. I mean, because what you're getting at is, like, you can flip those data sets and be showing, like, guess what, it's bad if you're, fill in the blank category, which is, again, just descriptive. But I think what people should think about is try to ask your questions so that when you get your results, there's an action that can be taken, right? So the leukemia paper that I used as an example of, my own participation in knowing doing gap activities, what we actually asked is about whether or not Black and Latino adults with acute myelogenous leukemia had specific, like a differential distribution of a positive prognostic marker. So it's a genetic marker that's actually in the a genomic marker that's in the California Cancer Registry. So we wanted to pull that out because we say, well, if that's the case, then that might make things hard. But of course, what we found was that those markers were disproportionately expressed in Black and Latino community. They have targeted therapies. So why are the outcomes worse? Is it possible that these, A, not getting tested for, and B, targeted therapies not being applied, right? That would be your natural conclusion. That would be the next thing to either test or intervene on. So try to frame your questions so that when you get your results, there's actually an action that can be taken. Don't just generate, well, it's fun, like you don't have to write it up, but like to just generate correlations, right? Like clinic B, their patients have an increased time to treatment. So what you could then go and look at clinic B, but that's just kind of for the sake of it being fun, right? Instead, you could ask, if you have a group of people who have longer times, you could actually interview them. What happened in your treatment process, right? What got in the way? Was there something? Did you get treated elsewhere? Because we don't really know, right? So I think that the idea is to start to craft policy relevant questions. And by policy, I mean, it could be small p policy, like your internal hospital policy, not just your state level policy or your federal level policy, but ask questions that are going to be policy relevant, that you could actually make a change to intervene on the results that you find. And you should ask yourself, like, while you're making your questions, like, okay, what are we going to do if we find that yes, it's true, or no, it's not true? What are we going to do about it? Because then that's what you can say in your conclusion, or instead of saying more research is necessary, right? So we all like, I don't know what to conclude. Well, more research is necessary. Like, no, an intervention is necessary. And that intervention might look like this because it hits along our conceptual framework in a particular way that would change the trajectory of outcomes.
And I know we're down to our last minute. There was one other question about lack of representation on the medical side. So even when you have buy-in from the community, how do you navigate that when there's a lack of representation on the physician side? I know we have like a minute left.
Yeah. So what I'll say about that is that's important, but it is not the only thing. And the example I will give to counteract that is, for Umoja, it is intentionally Black, but not exclusively Black focused, right? And what we say is, you don't have to be Black to work in Umoja. You just have to be on the same mission. And so what I would counter by saying is, we can all be working toward these goals, but we actually have to commit to the mission. And so, yes, Black people want to see Black doctors, but all skin folk ain't kinfolk. All skin folk ain't kinfolk. And I just want to repeat that, because there are ways that the structure can control how people behave in the situation that might not look like what you would expect because that person is Black or brown. So I want us to get away from the idea that you got to look like the people you're working with. In our cancer center, our catchment area is 25 counties. I work with rural people. I work with Pacific Islanders. I work with the Chinese community. I work in the Latino community, and I work in the Black community and the rural community and the LGBT community. I don't have to be all of those things. I just have to be on the mission. So it's important to diversify the workforce. We're not going to be able to do that without the relationships that I talked about. All of those young people that I told you about, that's the way we're going to get to a diverse workforce. In the process, I hope people are learning and thinking about what it takes to be in relationship. Because if you wait for us to look as diverse as the rest of our catchment area, just say, it's not going to happen. And then we're going to be stuck. And then you're going to be like, well, we can't really do it because we don't have the diversity in the workforce. That means we're stuck in the status quo. So don't be so focused on that. Be focused on being in relationship with community, and that will be a natural result or outcome of having that relationship. That's what I would recommend. And
Right.
also, I'm sorry, if you say it has to be diverse in order for the patients to be comfortable, it not only, I mean, it disenfranchises the people who want to be on the mission, who feel like they can't be part of the mission because they're not the right color. And I think that misses the point.
There are no further questions. Thank you so much for taking the time. We learned a lot, and I will definitely be bugging you. And it looks like there may be more questions coming through the pipeline over the next few days as well.
Awesome, my pleasure. And just so for the trainees to know, it's been 3 years in the making, but we are on the verge of getting a ginormous data set that combines the inpatient process with the ambulatory and ED visits in about 10 or 12 different cancers with neighborhood level measures, with, with the kind of data that I showed you at the top of the talk. So maybe we should make an announcement when we finally get the data in hand. It really has been 3 years in the making. So please be in touch.